So hello, welcome to the Bowen YouTube channel. Today, after some requests, we're going to look at filming a treatment in the chair. So how do we treat somebody sitting in a chair? So there's lots of reasons why we might be sitting in a chair. We might have somebody that is feeling uncomfortable about lying on a bed. They're not able to lie face down or face up very comfortably. They might be elderly, and the whole process of getting them onto the table is something that's a little bit convoluted or difficult. So we can sit them happily in a chair and treat them that way. You might be also out somewhere where there isn't a table, there's no table available, so it's just an easy thing to do, is to treat them sitting up. Alright. There's a couple of things. This might also apply to a wheelchair, so if you're treating somebody in a wheelchair, there's a few other different things we need to check as far as treating a wheelchair, but we'll try and find somebody later on to do that with, or another time to do that with. But for the moment we're going to stick to the chair and we'll see how we go from there. Okay, so this is Jenny, and Jenny is elderly and infirm. Well, she's not elderly or infirm, but she's going to be a perfect model for us to practice on as far as our, I don't know why she's more perfect than anybody else, but anyway, she's volunteered to be our model for us working on a chair. So the principle of working on a chair is essentially the same as if we were working on the bed. We're going to do, the moves are going to be exactly the same, it's just that we have to adapt things a little bit to be logical. There's a logical aspect to it. So, for example, if we just come around here and have a little look, what I'm going to get is to get Jenny to sit forward. I'm going to get down to her level. So I say, sit forward for me, so she leans forward. If there was a bench or a table or something here, she could lean onto that and she could lean forward, then that would be fine. But so just imagine you're leaning forward there, put your arms up there, so she's leaning forward onto that bench there, and we could lean her forward that way. But in this instance, we're just going to sit her forward, just shuffle forward a little bit, assuming she's mobile enough to be able to do that. And here we can come in here and we can put our stoppers into this lower back in here. For 3 and 4, again, assuming that she's got this ability to be mobile, I'm just going to push my fingers underneath or around into the glute there, and I can get 3 and 4 pretty much the same as I would do with her lying on the table. Can you see that into that little corner there? That's it. Okay, there we go. And again, I'd be moving around the table, around the chair rather, to do the other side. 5 and 6, my holding point, no different at all. I'm just going to push my fingers up underneath and hold, and I'm going to use my fingers into here to move outwards. Yeah, so just my fingers would make the move here, and the side of the leg would be here a forward move rather than a posterior move. So the traditional move will be backwards, but the logic behind that is the fact that she's going to be lying face down, and so therefore the move would be this way. It would be this way with my hands. When she's sitting up, it still would be this way with my hands. The difference between moving backwards and moving anteriorly and moving posteriorly is absolutely zero. It makes no difference at all when you look at the anatomy and the physiology of the iliotibial band and where it goes to. So whether you're going that way or that way, it's just you don't want to trap that tissue between your thumbs and the table. So there's a logic involved in that. When we come to hit the lats, we can move the knee forwards and backwards. If there was something that she was needing to put her foot on, so we could put the a book or a towel underneath her knee, underneath her foot, to be able to lift the knee up if she couldn't move it forwards. And again, the same principle here is I'm ready to get in here and make the move on the lats, no problem at all. There's certain procedures I couldn't do, so I couldn't do the hamstring, for example, lifting the leg up and putting my elbow in there. I'd have to bring my fingers around and try and work down the inside of the hamstring that way. And similarly, things like the diaphragm, you know, if I tried to lift a leg up and out in the diaphragm or a kidney or a coccyx move, then she'd fall off the chair. And I think that would probably, on balance, be seen as not a good thing. I don't know how you feel about that, but me personally. All the other moves quite accessible here. So again, she's leaning forward, sitting forward, and I can get into my mid-back, my laces into here, my upper stoppers. I can get around the shoulder quite happily, around the ladybird up onto the top here. I can do any of my additional moves up into the thoracic and cervical spine, particularly around this this junction here, this thoraco-cervical junction, T1. Page 3 again, I can also get into these moves up into page 3, up into the base of the neck, or BRM3 here, back of the head, and 5 and 6 on these as well. So for example, with the diaphragm move, I just sit her up here and I would move laterally this way and this way with the posterior diaphragm moves, and then I'd come round and do the anterior moves. I'm running around, I'm making life good to see you making you run. And we do the anterior moves exactly the same. I'd be on the opposite side of the chair, exactly the same with a holding point either side of the diaphragm moves as well. So it's very, very little different. I probably wouldn't try not to do the coccyx. I think it's going to be an awkward thing to try and do a coccyx on somebody sitting up. It's just going to be, I mean, if they were standing, again, we could probably do it that way, but just sitting up, I probably wouldn't try and do it. Pelvic, absolutely no problem. The pelvic video is already up there, so again, same sort of thing. I'd get somebody to put their hand there. I'd be into here to be able to make our moves into adductor longus, sartorius, and again from here, inguinal ligament is a small step away, and the lats we've already looked at. So it's just about being adaptable and about being logical, applying the flexibility. It's always better to do something than nothing. In a wheelchair, sometimes you can take the sides off the wheelchair, and that makes life easier, difficult, different, easier. So taking the sides off the wheelchair can make life a bit more easy, but again, make sure that the wheels are locked.
Bless you.
Excuse me. Where will we get to before that?
Make sure the wheels are locked. Take the side down on the wheelchair. So
in a wheelchair, sometimes you can take the sides off a wheelchair. If it's an electric wheelchair, make sure it's locked, it's switched off, and on a manual wheelchair as well, make sure the wheels are locked and that you're not going to be moving somebody around when you treat them in that wheelchair. But again, I always assume that the fact that some people are more easily able to transfer than others, so we can get people off that, out of that wheelchair and onto a table or onto a bed, sometimes quite easily. So if possible, get them onto there, otherwise sitting down. So hopefully that's been useful for you. Please be flexible and adaptable in your treatment. So don't think that you have to stick to a rigid regimen and that you have to stay working according to any kind of protocol or format. You need to work according to what your client needs rather than necessarily what you think the strict rules are, because they're not as strict as you might think they are. So I hope that's useful. Leave some comments and some thumbs up or thumbs down or whatever the YouTube thing is, any requests that you've got, and enjoy.